I'm going to talk to you today about infant mortality. And although that sounds like a very morbid topic, and certainly each infant death represents such a tragedy, these babies have something to tell us about the communities in which they were born. There's a lot for us to learn from this statistic. It's a vital sign of the community's health. And so I want to show you how to look at it and to try to give you a little bit more perspective. So I'm going to cover the definition and the meaning of infant mortality. I'm going to talk to you about how it varies from place to place geographically, how it has varied over time. Look at some of the causes that are most common for infant deaths. Look at the risk factors, and this is probably the most important part of what I've got to say. And then we're going to look at Worcester, Massachusetts, and the profile of Worcester, Massachusetts, what makes it different, and some thoughts about infant mortality rate in general and health, and what we can learn and how we can understand these numbers. Now, the definition of infant mortality is the number of infants under a year of age per 1,000 live births who pass away or die. So this is how the statistic is developed. There are things that you might think are in here that are not. For example, stillbirths are not counted in the infant mortality rate. And we'll talk about that a little bit later, but it's important for you to understand the basic definition. And the infant mortality rate is certainly affected by the medical condition of the mother, the medical condition of the baby. This terminal event is certainly what gets put on the death certificate. It's what we think of first. But know also that it's affected by smoking and other substance abuse, by deficiencies in housing, diet, stress, the general environment, genetics, education, poverty, marital status. Just about everything pours into it, and that is why, in analyzing it more deeply, we gain understanding. This is the framework that I want you to consider when we go over the various risk factors and conditions. So certainly you know that the initial health of the child plays a great role in its risk of not making it to its first birthday. But the health of the mother pours into this as well, both for her ability to care for the infant as well as the conditions that may have affected her pregnancy. The family and the financial, emotional support, help with raising children, the things that you know make such a difference in a secure family unit. And then there's the community, which we may not always think of, but certainly roads, utilities, schools, healthcare, jobs, safety, housing, water supply, sewage, all these things play a role. And these are the things that you need to have in mind when you think about what could be contributing. And then finally, there are the safety net services, the social services, and the healthcare that certainly can make a difference. But very often, these play the role of trying to mitigate circumstances that arose for other causes. Now, if we look at the effect of geography in infant mortality, I'm sure you've heard that the United States has an infant mortality rate that is 20th or 30th or 50th, pick a number, from the top in the industrialized world, and that it should be much lower than it is. Know that within the United States, that Massachusetts is consistently in the top 3 or so with regard to low infant mortality rates. And the most recent is measured at 4.1 infant deaths per 1,000 live births. If we look at South America, it's about 14. If we look at Africa, 60. Western Europe, 3.5. Japan consistently has rates that are in the low to mid 2s. And then, of course, the other geographic locations as well. Now, I've isolated Ghana on this map at a rate of 40 most recently, and the reason for that will become apparent when we talk a little bit more about Worcester, Massachusetts. But this gives you an idea. The lowest infant mortality rate in the world is probably Japan, or Japan is close to it at 2.4. The highest infant mortality rate in the world at this time is in Afghanistan, and it's about 150 infant deaths per 1,000 live births, so 15% of the infants that are born do not make it to their first birthday. Now, if we look at a different way of analyzing this world infant mortality, the world infant mortality rate is about 17 or so, and this accounts for roughly 5 million infant deaths per year. Africa accounts for 40% of those deaths with their infant mortality rate of about 60. And then Southeast Asia with 1.5 million. And then going down the list, we can see that the Americas, North America, South America, Central America, about 200,000. In Europe, about a little over 120,000 infant deaths with their infant mortality rate in the 5 range or so. Now, if we were to tease out the United States from the Americas, what we would see is with our infant mortality rate of just under 6, 24,000 infant deaths per year. And in fact, if we were to tease Massachusetts out of that, we wouldn't be able to see the dot. It would be about 350 infant deaths per year out of the 70,000 or so births that occur in Massachusetts. If we look at the United States, as you may expect, there's a wide variation. I'd mentioned to you that Massachusetts consistently has the lowest infant mortality rate, or among the lowest. And you can see that in the Northeast and in the far west, the infant mortality rates tend to be on the low side. In the South, they tend to be higher. And that is fairly consistent year after year. Now let's look at time. What has happened to infant mortality rate over the decades? And this graphic shows what has happened in Massachusetts from the mid-1800s to the mid-2000s. And you can see that as people moved off the farm and into the town during the Industrial Revolution, the infant mortality rate actually went up and was hitting in the 160 range or so at that time. But you can also see that starting in around 1890 or so, there was a fairly steep decline. And this occurred with the hygienic movement, the improvement in water supplies and safety. Things such as that made a big difference. It wasn't until the late 1930s, early 1940s that even half of deliveries were occurring in the hospitals. And it wasn't until the mid-1930s that antibiotics and vaccines started to come into common use. Fetal intervention in the mid-1960s made a difference, but again, you can see the lion's share of this improvement occurred even before that. And now we're going to look at Worcester, Massachusetts, over the past 20 years or so. And what we see is that a rate that was in the 8 to 9 range fairly consistently for the 1990s and early 2000s, and then a trend down since about 2010 to the vicinity of 6 currently. However, each year it has been higher than Massachusetts, and in fact higher than Boston as well. And looking again at the effect of time as far as what the causes are and the number of infant deaths in the city of Worcester, we see that in 1906 there were nearly 4,000 births, but there were 513 deaths for a rate of 130 roughly, whereas in 2014 there were just under 2,500 births and 16 infant deaths with an infant mortality rate of 6.7. In 1906, 1 in 5 deaths that occurred in the city were infants, and in 2014 it was less than 1 in 100. So that's important to know. Also important to know is the fact that prematurity is currently responsible for the overwhelming number of infant deaths. Some were due to malformations. Most recently, none due to infection, although occasionally one will occur due to that. And yet in 1906, there were 275 infant deaths due to infection, and there were 46 infant deaths who were infants who died due to malnutrition, reflecting just what a tragedy it was in those days. Now today, because prematurity is the most common cause, 3 out of 4 babies die within the first month of birth, and 40% die on the first day of birth. Now, I worked with a medical student a few years ago, and we reviewed the infant deaths at 10-year intervals, starting in 1906 for 100 years in Worcester, looking at what the rate was and what the causes were. And you can see from this graphic that the big causes were basically prematurity and infection. There were some other causes in there as well, but it gives you a sense as to how that has changed over time. And when we look at what has happened to infection in Worcester, and also look at concurrently when antibiotics came into use, when the vaccines came into use, what we see is that 80% of the drop in infant mortality in Worcester occurred before the advent of antibiotics or vaccines that were put into common use. And this is, again, emphasizing the fact that environment, hygiene, certain supplies, such as clean water and the like, certainly can play a big role. If we look at malformations, a different story. The rate of deaths due to malformation were fairly consistent, a few ups and downs, until the mid-60s. And it was at this point that neonatal intensive care units came into use, that operating on newborn infants became possible, amniocentesis and ultrasound to assure maturity, but also to detect malformations. And Roe versus Wade occurred in the 1970s and led to the potential for terminating pregnancies for a number of reasons, including malformations. In the 80s, we started to test women for a blood chemical called alpha-fetoprotein, which helps us to detect certain abnormalities. Folic acid supplementation came into common use, which lowers the risk for certain malformations. And therefore, during this span of time between the mid-70s and the mid-2000s, over 80% of the drop occurred during this span of time. Keep in mind that we're not decreasing necessarily the incidence of malformations by 80%. Rather, we are decreasing the live births that result in death by about 80%. If we look at prematurity, again, we're looking at a huge improvement since the 1960s with the neonatal intensive care units. Again, amniocentesis, ultrasounds, fetal distress being diagnosed and leading to cesareans, which in some cases leads to a delivery of a healthier baby. And the use of corticosteroids in women who are threatening to deliver early, which can lower the risk of respiratory distress and lower the risk of death for those babies. So here, almost 90% of the improvement for survival for premature infants has occurred since the mid-70s. So let's talk a little bit about prematurity. Well, the general definition is that it's less than 37 completed weeks of gestation. This, however, can be defined further by saying that extreme prematurity is less than 28 weeks completed. Low birth weight, so instead of going by number of weeks, we go by the weight of the baby. In 2,500 grams is how we define low birth weight, which correlates roughly with 36 weeks pregnancy. And very low birth weight, which is 1,500 grams, which correlates roughly with around 32 weeks along, is another measure that is commonly used. Very low birth weight is worth paying attention to, almost more so than prematurity in general, because that particular level of prematurity, the very low birth weight group, has a risk of infant death that is increased by 75 times. And what are the risk factors for this? Well, multiples, such as twins and triplets. Twins will increase the risk of low birth weight and infant death by 5 times. Maternal age, either very low or very high. Low socioeconomic status. Uterine abnormalities, uterine fibroids, which are growths within the muscle of the uterus. Maternal use of drugs, infection. These are things that can trigger a premature delivery, particularly of a low birth weight infant. And what can we do to prevent it? Well, in women who have recognized risk factors, particularly women who have previously delivered a premature infant, the use of progesterone has come into use, and it's felt that this does decrease the risk of premature delivery if the woman has not gone into labor yet. Also, for women who have abnormal shape to their uterus, such as fibroids or other abnormalities, surgery on the uterus is another way of preventing a woman from going into preterm labor. But you need to understand that we have no good treatments for premature labor once it starts that will prolong the pregnancy more than several days. A number of things have been tried, and if we look at the incidence of premature labor over the past few generations, it has not really gone down. If anything, it may have gone up a little bit. So it occurs, and once it starts, we don't really have a tremendous amount of success stopping it, but we do have some success in trying to mitigate the effects using the corticosteroids I'd mentioned earlier, or antibiotics, or also magnesium sulfate can be administered to the mother and lowers the risk of some central nervous system problems for the babies. So I'd mentioned multiples to you, and when we talk about medical intervention, we're used to thinking in terms of medical intervention making things better. But I think it's worth pausing a little bit in looking at the issue of multiples, because in the late 1980s, Massachusetts passed a law mandating insurance coverage for infertility, which led to remarkable growth in the use of in vitro fertilization, to the point where the rate of in vitro fertilization in Massachusetts became the highest in the country. And along with that, the rate of multiple pregnancies became among the highest in the country. The natural rate with no intervention is usually a little over 2 per 100. 2 babies per 100 will be twins, and even much more rare triplets. But what you see here is that over a period of about 10 years after the law was passed, the rate of multiple pregnancies went up to about 5. Starting in around 2000, the ability of the infertility specialists to have a successful pregnancy improved, and they began to recommend single ovum transfers rather than putting multiple eggs into the mother. And this has decreased the rate of multiples a little bit, and hopefully that will continue to improve. But I will tell you that I looked at the figures for Massachusetts in the mid-2000s, and found that if we look at very low birth weight infants, those high-risk babies that weigh under 1,500 grams, that 1 in 3 in the state of Massachusetts was a multiple. So again, this is a situation in which technology was a solution to one problem and a problem as well. So let's get into certain risk factors. We've gone over causes and conditions, and let's go over risk factors and look at social determinants of infant mortality and also social determinants of premature delivery. How much do these items, which can fairly easily be identified from the information that is collected at the time of birth, how much can these items change the risk of infant mortality and prematurity? And the answer is teen pregnancy increases it by about 70%. If we look at education and look at college graduates versus high school dropouts, there's about a 50% change there. If we look at unmarried versus married women, the rate of increase is anywhere from 60 to 90%. Poverty nearly doubles the risk of infant mortality, and smoking increases the risk by about 60%. Now, I'd pause you here and let's think about teens a little bit, because the vast majority of teen pregnancies and deliveries are women who are 18 to 19 years old. And when we look at that age group, we're not necessarily looking at a medical or physiologic deficiency. What teens are identifying really are the other things on this graph. They are people who may have little education, are unmarried, poverty, more substance abuse and smoking. It is those other things that pose the risk for teens, but physically or physiologically, they're probably in as good a shape as any. So it's worth considering that as we think about how to improve outcomes. Now, how is Worcester different than the rest of Massachusetts? Well, our teen pregnancy rate is about 50% higher. We have 50% fewer college graduates than the state as a whole, and right now, women delivering in Massachusetts, about 40% have a college degree. About 50% more of the women delivering in Worcester are unmarried, and about 50% more of the women delivering in Worcester have payment for their care through government sources, which is a simple identifier for poverty. Now, this graphic looks at the risk of, or the incidence rather, of teen pregnancy, and it breaks it down by race and ethnicity and gives us how it's improved over the 10-year span from 2004 to 2014. And this is for the state as a whole, not for Worcester in particular. But basically what you can see is that depending on race and ethnicity, you have widely differing rates. So among the Caucasian population, it has gone from about 13 per 1,000 females aged 15 to 19 down to 5.4. For the blacks, it's gone from about 38 to 15. For Hispanics, 75 to 36. So the Hispanic group has a rate which is a multiple of the rates of other groups within the state. And the Asians have a low rate as well. But the main thing to understand here is that this varies by race and ethnicity even when it has improved. If we look at Worcester and compare Worcester to the state, you can see again that we are dealing with rates that are a little bit higher for the Hispanics, a little bit higher for the blacks, considerably more for the whites, and overall about 50% higher. What this translates to is that if we look at the teen pregnancy and break the Hispanic group down into those who were born in the U.S. or Puerto Rico, 1 in 8 pregnancies are teen pregnancies. Whereas if we look at the non-U.S. born Hispanics, it's about 1 in 20. If we look at U.S. born blacks, the African Americans, it's about 1 in 13. But if we look at the African born mothers, it's about 1 in 200. So again, sometimes analyzing different groups is useful, but sometimes we're bunching people together that really may be a little bit different. And again, looking at Worcester, we see that there's a higher single parenthood rate, that this has gone up some over time, and that the poverty rate pretty much tracks the single parenthood rate. So we're looking in terms of roughly 50% of the births in Worcester to single mothers, and a government support rate that is a little over 50% in Worcester. Now, we can see this trend from the late 90s to currently and how it's gone up by roughly 10%. But we can get a more global view if we look at Massachusetts over the past couple of generations. And what we see there is that in the mid-60s, the rate was 4% for single parents. Mid-70s, it went up to about 11%. The mid-80s, we were dealing with a little over 20. Mid-90s, mid-20s. And then we crossed 30% in the state in the mid-2000s. So this represents a fairly steep increase over a period of time. The health effects of this, the economic effects of this single parent have not improved over time. And so if we're trying to identify risk factors that may be exposing mothers and children to greater health and socioeconomic risk, this is certainly something that's worth paying attention to. Now, in thinking about how to address some of the risk factors, those of us who were analyzing the data tried to look at different levers and reanalyze the information that we had. And using Massachusetts information, what we found was that education might be one area to pay attention to at the community level. That if there are ways of decreasing high school dropouts, increasing college graduates, what you can see here is that several of the risk factors that I had just mentioned to you melt away with a college education. So maybe that is one area that bears a closer look, and perhaps we should look at how that is going in Worcester at this time. What we see with this graphic is that depending on the race, I've compared the state of Massachusetts and Shrewsbury, a suburb of Worcester, to the Worcester School District. And the graphics show of students who were entering the 9th grade, how many graduate from high school within 5 years, how many enroll in college, how many stay in college for at least 2 years, and then how many obtain a degree within 6 years. That's what this graphic shows. And what we see is that for the 9th graders entering, among the whites, about 24% will graduate from college. Among the blacks, about 22%. But among the Hispanics, it's only 7%. And this is certainly something for us to focus on, particularly among the Hispanic group, which seems to be particularly distressed in this measure. Now, another measure for us to look at is a condition called mobility. This is something that the Department of Elementary and Secondary Education pays attention to. And this is the chance of a child entering school in September and being there in June. So this is called mobility. And again, if we look at the breakdown based on race and ethnicity, we will see that in Worcester, roughly 1 in 7 whites, roughly 1 in 5 blacks, and roughly 1 in 5 Hispanics will not be there. This range, depending on the school, can be as high as 40%. And this represents a number of things we need to pay attention to. It represents a challenge to the schools to teach students who aren't going to be there for even one season. And it represents a disruption in the class because each time a new student comes in who hadn't been there since the beginning, everything stops a little bit as that student gets brought up to speed. And then thirdly, this represents a home and a family that are in distress, a home and a family that is got a lot of things to worry about besides the education of the child. There are likely problems with housing, with food, various other factors that could be pouring into this and that are conspiring to work against this child being successful in school. So let's look at a couple of subgroups in the city of Worcester who've had particularly high infant mortality and see what we can learn from them. The Hispanic infant mortality in general was as good as the white infant mortality until the early 2000s. Blacks, on the other hand, had an infant mortality rate that was nearly third world level in the mid-1990s. That has trended down. Both have had a bit of a bump, but we'll go into these in a little more detail. So if we look at the Hispanics, the interesting piece here is that this is a group, which I mentioned to you earlier, has a number of risk factors that place it at higher risk with single parenthood, poverty, and the like, and yet their infant mortality rates were really quite close to the state as a whole and to Boston for some time. This is something that gets referred to as the Hispanic paradox, meaning that this particular group, if one looks at the socioeconomic stressors that they are exposed to, actually does better than we'd expect. Even when they're doing worse than ideal, considering the conditions that they're exposed to, they have been doing better than we'd expect. And yet for reasons that really weren't terribly well defined, in Worcester and in Worcester alone, during the mid-2000s, particularly during the recession years, the infant mortality rate shot up among the Hispanic population, and fortunately it is coming down, but that was something that caught our attention and we tried our best to look into in a little more detail. And again, mentioning the additional risk factors, if we look at the unmarried status, the poverty status, and also if we look at college graduates among this group, we see that at a time when the college graduates were 25% for the Caucasians in Worcester, they were about 6% for the Hispanics, reflecting, among other things, a socioeconomic stressor that could make things worse. And again, if we look at disparities by race and ethnicity as far as graduates not going on to college, we see that the Hispanic group tends to fare a little bit worse than the other groups in the city of Worcester. Furthermore, if we look at a breakdown between males and females, we see that males are doing considerably worse in the city of Worcester with regard to how many are going on to college. And this is something which in some ways may be contributing to the single parenthood, since the number of males who feel in a position to support a family may not be reaching its potential. Now let's look at the blacks in Worcester, and you saw that they had an infant mortality rate that was in the high 25 to 30 range in the mid-1990s. and has been coming down. Again, a bump during the recession years, but has been coming down. In analyzing this a little bit more, we looked at the black births in Worcester. And what we saw was that the U.S.-born, the African-American black births were actually decreasing during much of the 1990s. And during the mid-1990s, the number of births to foreign-born black mothers, particularly African, and of the Africans, particularly those from Ghana, were increasing to the point where today, roughly 80% of the black births in Worcester are to foreign-born mothers. And in fact, today, if we look at a lot of the U.S.-born mothers, they're probably first generation, since the cohort that was born in the early 1990s of foreign-born mothers are probably just getting to reproductive age. So if we look at some of the spread of some of the socioeconomic factors, the teen pregnancy rate, the single parenthood rate, the rate of college education, you can see quite a variation depending upon where they come from. And you can see, for example, the teen pregnancy rate, particularly in the Ghanaian and Nigerian population, is next to nil. The college graduation rate is nearly the same as the Caucasians among the Nigerians. And the single parenthood rate, although higher than among the Caucasians, is considerably lower than that among the African Americans. So the profile varies there. And again, this is a situation in which we are putting two different populations into the same grouping for birth recording, and maybe that isn't the most accurate way to analyze it. If we look at low birth weight and very low birth rate, that very high-risk category I'd mentioned to you, what we know is that among the Caucasians, the very low birth weight rate, the rate of babies under 1,500 grams, is a little over 1%, maybe 1.1, 1.2%. Among the African Americans, it hits about 3%. But look at Ghana. Ghana has an infant mortality, very low birth weight rate of over 5%. This is as high as twins. And it represents a difference not only between the Ghanaians and the Caucasians or African Americans, but even among other Africans. And so again, it hints that there may be either some exposure difference or some genetic difference that we need to pay a little bit more attention to. And if we look at the native country infant mortality rates, 40 to 50 is not an unusual one in Ghana. If we look at Nigeria, it can get up to about 90 or so, whereas African Americans, which often have an infant mortality rate that is considerably higher than the Caucasians, have a rate of about 11 or so. This is important to know, but also important to know is the fact that when we look at places such as many of the African nations where the rates are very high, there's a better than even chance that those rates may actually be underestimates. I had occasion to speak to one of the health ministers in Ghana and brought up to him the fact that in the city of Worcester, the typical profile is for the mother to come in between 20 and 24 weeks along, rupture membranes and deliver shortly after. And I inquired as to whether he had a similar experience in Ghana. And he said he wouldn't know, because that particular group probably wouldn't make it to the hospital. They deliver at home and they wouldn't know about it. So if we look again at Worcester, where most of the losses are, that's where they were coming from. And therefore, even these statistics may not tell the whole story. So we look at the role of education and marital status and race, and I think buried in there is the suspicion that if we were able to correct the socioeconomic issues, the differences between black and whites may go away. So I was able to look at the rates of low birth weight in Massachusetts among singletons and compare whites to blacks and compare the marital status and the educational status among the two groups to see if we could try to mitigate these problems. And what we found was that among the higher risk group, the single mother, less than high school education, these were the rates of low birth weight within those groups. If we then looked at single mothers with a college graduation, both improved, and so that is what we would expect. If we looked at married mothers with less than high school education, interestingly, this rate is even lower than the single mothers with college degrees. And this number actually holds true even nationally. The difference is not great, but interestingly, even with the 4 million births that occur in the United States, if we analyze it this way, the difference, the order of these improvements is about the same. And then the group that probably has the best socioeconomic status, married college graduates, again, a drop occurs. Now, what's interesting here is that if we look at the total drop among the two sides for improving these socioeconomic factors, they're about the same. And so improvement did occur, but it didn't make the differences go away. There still remained a difference, which may reflect something. It may reflect a genetic problem or something else. When I was doing this research, there was some literature on something referred to as heat-stable protein 47, which was a component involved in collagen synthesis that was involved with weaker collagen, weaker connective tissue, a greater risk for preterm premature rupture of membranes, which, as I'd mentioned earlier, was a big part of the picture with the very preterm deliveries that we were seeing in Worcester. And interestingly, this study looked at blacks and found that the rate of this particular protein problem was greater among the blacks than among the whites. And so it was tempting to think that this might be some hint as to a genetic issue that could be addressed and hopefully improved in some way. So that's the big picture. We've looked at a lot of different things, but here are a couple of other thoughts on education, socioeconomic status, and health. There are a number of other pieces of research that have looked at the value of socioeconomic status and education on health in other ways. There was the Whitehall study that began in the late 1960s in England and was looking at government employees in England and their various ranks and statuses. There are about a dozen or so. And what they found was that the higher your rank, the longer you lived. The study has since been expanded to look at people outside of the government, to look at other factors, to look at health as well as longevity, and that stands. What they found was part of this is explained by healthier living habits, but not all of it. And there's a strong suspicion that elements of stress and autonomy and things such as that certainly play a significant role in the health of people. There's the Harvard Men study, which began in the 1930s, looking at men who went to Harvard and trying to track them for the rest of their lives and see what factors poured into their longevity and health as well as other issues. And another study that was being done roughly at the same time was poured into the Harvard Men study, but it was a very different population. It was inner city boys in Boston, Massachusetts. And what they were looking for is what factors contributed to poor outcomes, such as going to jail and the like. And what they found in that group over time was similar to what they found in the Harvard Men study, which was that if you were a Harvard grad, perhaps came from a upper middle class background, if you made it and graduated, your longevity increased by about 7 years. And if you were an inner city boy in the city of Boston, and you somehow made it and went to a less prestigious school, that you also gained 7 years of longevity from the benefit of a college education. So those are different factors, looking at different populations, but highlighting the same issue. And I think one thing I'd like to mention to you is we talked about teen pregnancy going down, and that is a good thing. But one bit of information that is out there is that in some populations, the average age of childbearing is going up. In other populations, not so much. And if we were to look at Massachusetts, for example, the average age of a mother is now over 30. And nationally, if we were to use 30 as a dividing line, what we find is that among women who deliver their child under the age of 30, that the incidence of single parenthood nationally is 50% or higher. And that among this group, poverty is significant, probably at least 50%. And if we look at the women who deliver over 30, the single parenthood rate is only 5%. And again, the poverty rate is much lower. So when we think about teen pregnancy, maybe we should be thinking a little differently. Maybe we should be thinking about some of these other factors, because it certainly looks like that when we use age and analyze it for the other factors which we know contribute to poor outcomes, that the age may be moving up a little bit. Back in the early 1970s, when single parenthood was considerably rarer than it is today, interestingly, the average maternal age was 21. Now, the other thing I wanted to bring up is that gender equality is not necessarily a zero-sum game. I had mentioned to you earlier that 40% of males graduating from high school in Worcester, Massachusetts were not going on to college, whereas 20% of the women graduating from high school were not going on to college. And I think another problem that is evolving here is that I've mentioned to you the risk of single parenthood, but there may be situations in which women are finding that the availability of a husband who can support a family and provide for this newborn child may not be what we would like it to be. That it may be that by improving the educational status, improving the employment status of graduating young men, that we can mitigate the issue of single parenthood and improve the health of women and their offspring as a result of it. Now, one of the last things I want to cover with you is the vagaries of data. We have been talking about infant deaths, and what this graphic is the raw numbers, not the rates, but the raw numbers of infant deaths occurring in the city of Worcester over the past 14 years or so. And you can see what that number is. It's typically in the 15 to 20 range. But those are infant deaths. If we were to look at stillbirths, that's how it looks. And so you can see that the number over doubles. I'd also mention to you the fact that 40% of the babies who die in the city of Worcester are dying in the first day of life. Well, you can imagine that the conditions of a baby who dies in the birth canal leading to that, and the conditions leading to an infant death that a baby survives an hour, probably aren't any different at all. And so if you shift just a few babies from one column to another, you can significantly affect the infant mortality rate that can occur in the city. And so another measure that gets used, but it's not used on an international level, is the fetal infant mortality rate. To my way of thinking, that is a better number. It gives you bigger numbers. It allows you to analyze a little bit more. And it recognizes the fact that a pregnancy loss is a pregnancy loss, and that particularly the factors leading up to it can be addressed in a similar way. And there's still a third number that is lurking out there that we need to be aware of. And that is the termination rate. And what I've looked at here is the terminations of pregnancies that are 19 to 24 weeks along that are done at Memorial Hospital in Worcester. And the gap in the middle has to do with the availability of physicians on the medical staff who are doing this. But you can see that the rate is increasing after 2010, and that this is entirely possible that this could affect the infant mortality rate as well. Here's how. A woman comes in at 20, 22 weeks along. She's got ruptured membranes. She's counseled that the chances of carrying the pregnancy successfully are very low, that she might get an infection. And an option is terminating the pregnancy as opposed to waiting and seeing how things go. If they opt to terminate the pregnancy, then that pregnancy and its outcome move into the termination column and not the infant mortality column. So that's one way that can affect it, and it's also one way that can lead to a magnification in disparities, because culturally there may be some groups that are more receptive to that suggestion than others. So again, it's important to understand it. I do not have Worcester terminations at Memorial. I only have Worcester County terminations because the state does not provide that level of data. But you get the idea that I'm bringing up here, and the fact that it can influence these numbers. So we have talked about the fact that a number of things pour into this. It could be genetics in some way affecting the mother, not just the infant. It could be the environment. It could be various behaviors such as smoking and the like. It could be the education and the wealth, social support, and stress, self-esteem, perceived opportunity. These are things that can't be measured, but that does not mean that they are not important and do not deserve some sort of consideration. And then, of course, there's the variation in measurement that I just mentioned to you. So I hope I've given you a perspective now as to how to look at infant mortality, how to understand the particular numbers and what questions to ask, and most importantly, what you as a member of the community can think of to try to improve the health of the mothers and the babies and of everyone.